G'day, welcome to Emergency Medicine Topics in One Coffee. I'm Alan Giles, an emergency physician, and today we're going to talk about clearing the cervical spine in the patient who suffered trauma. Now, clearing the cervical spine and safely removing the cervical collar should be one of the early priorities in the patient's care. Not only does it decrease resource utilisation, it improves the comfort of the patient.
Item, the Institute of Trauma and Injury Management are advocating for the adoption of foam cervical collars in the initial management of injured adults that require cervical spine precautions. But for now, most of us still get our patients and we have to wrestle with a semi-rigid collar. So when can we safely remove it? Pre-hospital providers, triage nurses, and trauma team members tend to use the American Nexus criteria, the National Emergency X-Radiography Utilization Study, developed by Jerry Hoffman et al. And published in the Annals of Emergency Medicine back in '98. It's easy to use, as you only have to answer 5 questions.
1. Do you have any midline cervical tenderness? From the occiput all the way down to T1. 2. Do you look, smell, act intoxicated, or do you have slurred speech? 3. Do you have a GCS of 15? 4. Do you have any weakness or paresthesia anywhere? And finally, 5. Do you have any significant, painful, distracting injury? When we say significant, we mean the pain at the level of a fractured long bone or a large burn.
If not, off comes the collar. You've got to love that, and it makes great intuitive sense. The original validation study of Nexus had a sensitivity of 99.6%. But remember that in that original study, they were looking at fractures seen on X-rays, not CT scans. One later trial, where all the patients had CTs rather than X-rays, showed, not surprisingly, a lower sensitivity of 83%. Here are a few tidbits from Jerry Hoffman about using Nexus in the real world. It's purposely vague with no definition of intoxication or real definition of distracting injury, because it's meant to be used by a physician with good clinical judgment. If you think they're intoxicated, they're intoxicated. If you think they're distracted, they're distracted. Then, in 2001, Prof. Steele and his team developed the Canadian C.Spine rule, published in JAMA. This was found to be 100% sensitive for ruling out cervical spine injury, which was defined as any fracture, dislocation, or ligamentous injury. Remember, this is on X-rays, and detected 27 of 28 clinically insignificant C-spine injuries. That is, injuries that don't require stabilization, specialized treatment, and are unlikely to cause any long-term problems. Put up against Nexus in 2003, it was a bit more sensitive and more specific. Importantly, because that meant you could get more collars off earlier. Problem is, compared to Nexus, it's more complex to use. First of all, you've got to see whether anyone's got any high risk factors. Dangerous mechanism like a fall from elevation greater than 3 feet, an axial load to the head, high-speed MVA, motorized recreational vehicles, a bicycle collision, or if they're over 65 years old or have paresthesia. Any of these people, they need to be imaged. Then you go to their low risk factors. If you can't even put together one of these, you need to be imaged. They can continue through the algorithm if they've had a simple rear-ended motor vehicle accident, sitting in ED, ambulatory at any time, have had a delayed onset of neck pain, or have no neck tenderness. Finally, to stay low risk and avoid getting imaged, see if they can move their head 45 degrees to each side. If they can't, they get imaged. If they can, the collar stays off. Yay!
Certainly harder to remember than Nexus, but it does allow you to clear more cervical spine safely. So if you can't remember it, download an app or put it on a t-shirt. What many clinicians do in the real world is they do what I call Nexus Plus. That is, they utilize Nexus, but then add in some imaging for some specific mechanisms, those being axial load or a patient who's been thrown from a vehicle, or in elderly patients.
And remember that the imaging we're talking about is moving more towards CT scanning. CT scans for many people rather than just plain x-rays. But a discussion of that will take a new cup of coffee.
Thanks for listening, and I'll see you again for the next emergency medicine topics in one coffee. Ciao.